Frequent resites of peripheral intravenous catheters by Samantha Frankmore.
My PICO question. In an acute care patient with peripheral intravenous catheters, how does replacing an IV catheter only as clinically needed to maintain patency compared to recommended guidelines to replace the IV every 96 hours regardless of condition, affect overall patient perceived pain and discomfort from peripheral IV sticks?
PIVCs are the most used intravenous device in hospitalized patients. They're primarily used for therapeutic purposes such as administering medicines, fluids, and blood products. According to United States Centers for Disease Control, guidelines recommended the replacement of PIVCs no more frequently than every 72 to 96 hours. Routine replacement is thought to reduce the risk of phlebitis and bloodstream infections. Keywords, also known as mesh terms, that I use to find a lot of my articles are listed below: adult, attitude of health professionals, catheterization, peripheral, workflow, catheter-related infections, prevention and control, catheters, indwelling, patient safety, Centers for Disease Control, evidence-based practice, infection control, phlebitis, catheterization standards, device removal, peripheral economics, aged, device removal, incident, and time factors. Many times after a thorough PIV site assessment, a patient's PIVC will be patent with blood return after 96 hours. As per the hospital policy, the PIVC will be removed though, and the patient will have to have a new PIV placed. Now let's look at the case study. A 32-year-old Hispanic female was admitted to the acute care medical surgical floor with complaints of severe abdominal pain. Upon arriving to the floor, the nurse places a 20-gauge peripheral IV according to protocol, and it's placed in the forearm and is dated per protocol. The catheter is used for fluids continuous, and the patient is also receiving antiemetic medications through the 20-gauge peripheral IV. 72 hours pass since the nurse has inserted the peripheral IV in the patient's forearm. Per protocol, the patient's peripheral IV needs to be changed even though it is asymptomatic, flushes, and has great blood return. The orders are now to saline lock the IV and discontinue the fluids. The antiemetics are converted to PO medications since the patient is tolerating a general diet. Per the protocol of the hospital, the peripheral IV must remain intact just in case of emergency. The nurse is prompted to change and place a new IV and is unsuccessful twice. The patient is grimacing in pain and requests that another attempt not be initiated. The patient states, "I don't understand why I have to be poked over and over, and we are not using it. You are treating me like a pincushion." The floor is busy, and the other nurses are busy as well with their patients. The nurse obtains a new order from the provider to leave the current IV in place, as the patient will discharge within the next 24 hours. Resites of peripheral IV catheters. Where clinically indicated, PIVCs can be used for a prolonged duration with significant benefits to patients and practitioners. Fewer cannulations result in less pain, enhance the patient's comfort, and reduce the risk of infection. Replacement of PIVCs must be guided by clinical indication rather than number of hours or days. One of the review articles I found was based on a systematic review. Healthcare organizations should consider policies in which the PIVCs are changed, but only in the presence of clinical indication, such as signs of infection, occlusion, or infiltration.
Application of theory. Improving the patient's perceived pain and discomfort caused by the IV sticks is a highlighted problem that has an opportunity for improvement. Nurses identify essential and clinically relevant practice questions that can address through the evidence-based process. The Iowa model is appropriate and it has a clear correlation to the outcome determined from my PICO. The Iowa model can help nurses and other healthcare providers translate research findings into clinical practice while improving the patient's outcomes. When relating the Iowa model to my PICO topic, my PICO questions the current clinical practice and how we can better understand the patient's perceived thoughts, ultimately improving the patient's outcome. The Iowa model of evidence-based practice promotes quality care, guided nurses, and other clinicians in making decisions about clinical and administrative practices that affect patient outcomes.
And then below is my chart of a few of my articles that I reviewed. I felt that the most important one was the qualitative article as it pertains to the patient's perspective, but there's a few other ones that are listed below.